All right, everybody. It's Dr. Arafat from Vet Triage. Friday, November 29th, 4:18 p.m. Pacific time. We are going through this journal of veterinary surgery from 2015. And we're talking about this article here, which is the correlation between histopathologic, arthroscopic, and magnetic resonance imaging findings with dogs with medial cornoid disease. And shout out to Dr. Noel Fitzpatrick, who's a beast. This guy publishes on him. I don't know. He has probably the largest number of publications in history in veterinary field. He's remarkable. Anyway, shout out to Noel Fitzpatrick. I met him one time at a conference. Very impressive. The objective: to describe MRI, arthroscopic, and histopath changes in dogs with medial cornoid disease, and to identify potential relationships between these findings. A retrospective study: 25 diseased medial cornoid processes collected from 19 dogs. They had a subtotal cornoid ostectomy. A reference group of normal medial cornoid processes was collected from 9 dogs that were euthanized for other reasons. The results show that the histo findings were subchondral microfractures. Subchondral microfractures continuous with cartilaginous fissures, moderate to severe hypercellularity of the marrow space, trabecular bone necrosis, and articular cartilage degeneration. Moderate to severe disease was in all specimens. 3 distinct patterns of bone marrow lesions were identified adjacent to the medial cornoid process. Moderate correlation between modified outer bridge scores and MRI scores was found. No correlation between histopath and either MRI or arthroscopy. And I did pull up here because I forget what the modified outer bridge scoring system is. So it goes from 0 to 5. 0 is normal cartilage. 1 is chondromalacia, which is characterized by swelling and softening. 2 is fibrillation or lesions that don't reach the subchondral bone. 3 are fissures that reach the subchondral bone or small defects that don't reach the subchondral bone. 4 is subchondral bone exposure. 5 is aberrated bone. So 0 is normal and 5 is most severe. Okay. All right. Introduction. The idiopathogenesis is unknown, but includes isolated fragmentation or fissuring of the medial cornoid process. Symptomatic cartilage erosion within the medial compartment of the elbow joint can also occur. Radio-ulnar joint incongruity, trauma, genetics, growth rate, nutrition, ischemia, osteochondrosis. Radio-ulnar disparity and humeral-ulnar mismatch are the signs of incongruency most commonly described. Aberrant forces between the radial head and the radial incisure of the medial cornoid process through the strong bicipital brachialis tendon is one of the theories of medial cornoid process disease idiopathogenesis. Radiographs, computer tomography, and MRI have all been reported to be used. A recent study highlighted the lack of correlation between X-rays and scoping in the same dog. Radiographs also lack sensitivity to assess articular cartilage pathology. MRI has high soft tissue contrast, high resolution, capability of multiplanar imaging, so transverse dorsal and sagittal. Compared with CT, MRI has greater sensitivity for detecting subtle changes in bone architecture and in the adjacent bone marrow. Tissue differentiation at the bone cartilage interface is also better with MRI. Accuracy of MRI for detecting a free fragment of medial cornoid process was 95.5% compared with only 77% for radiographs. Sensitivity and negative predictive value were also higher for MRI. A histomorphometric study revealed that accumulation of subchondral fatigue microdamage is associated with fragmentation of the process. Fissuring occurs in the subchondral bone before gross fibrillation of articular cartilage develops. In another study, they did not identify any correlation between histopath, modified outer bridge score, and the International Elbow Working Group score. It has been suggested that MRI is useful for assessing subchondral bone disease, bone changes, and medial cornoid process disease. Early experience with MRI in people highlighted the existence of focal regions of hyper-intense signals. In people, bone marrow lesions are predictive of knee pain and subsequent cartilage degradation in patients with osteoarthritis. Early experience with MRI in people highlighted the existence of focal regions of hyperintense signals that are called bone marrow lesions. Materials and methods. This is data collected in 2009. Dogs with medial cornoid process disease they had any other disease of the thoracic limb, including osteochondrosis of the medial aspect of the humeral condyle or caudal humeral head, or ununited inguinal process, identified otherwise were excluded from the study. Those with a modified Outerbridge score of 1 or greater, affecting the articular surface of the medial aspect of the humeral condyle, were excluded. Incongruity, diagnosed by radio-ulnar step or humeral-ulnar incongruity on MRI, were also excluded. MRI was performed based on the score of the radiographs based on the International Elbow Working Group score and grading system. Only cases with a low score, less than 1 or lower, were included. For the MRI evaluation, the extent of synovitis, meaning the volume, the signal of synovial fluid, and the volume of joint fluid, the shape of the medial cornoid process, meaning abnormal, fissured, or fragmented, and the presence or absence and severity of the extension of any bone marrow lesions associated with medial cornoid process. Grade 0 meant no bone marrow lesion. Grade 1 indicates increased signal involving less than 50% of the medial cornoid process. And then grade 2 indicates over 50%. Modified Outerbridge classification. Here is the table on that right there, if anybody wants to read that. So what it says here is grade 1, signs of chondromalacia, namely softening and swelling. 2 is partial thickness fibrillation and fissures of the cartilage. 3 is full thickness fibrillation and fissuring. 4 is full thickness cartilage loss. 5 is full thickness loss with subchondral bone eburnation. And then here you have an MRI of an elbow, and then arthroscopy of the elbow, and then they show you there which bone they remove for right there for the medial cornoid process, and they show you the biopsy with 3 different stainings that they performed on these dogs. The tissue sampling for the medial cornoid process was collected through arthroscopic assistance or via mini arthrotomy. Results. Operative reports, MRI scans, and resection specimens were obtained from 25 elbows from 19 dogs with medial cornoid process disease. The final control series, therefore, included 12 unaffected elbows. Labradors made up 64% of elbows. Male dogs, 53%. 60% of those were castrated. 26% were spayed females. The mean age was 36 months. Mean weight was 31 kilograms. Control dogs were found to be weighing less than the affected dogs at 25.3 kilograms, and mixed breed was the most common control dog. MRI evaluation. As expected, MRI scores of diseased medial cornoid process was higher than those with normal controls. A moderate but significant positive correlation was identified between MRI and the Outerbridge score. Focal bone marrow lesions involving only the tip of the medial cornoid process were found. Focal/linear bone marrow lesions within subchondral region were found, and diffuse bone marrow lesions involved the whole medial cornoid process. Arthroscopic evaluation found a mean modified Outerbridge score of 2.6. Descriptive histopathology, the marrow space in 84% of specimens was hypercellular compared with controls. Trabecular bone necrosis, evidence of empty osteocyte lacunae, was present in 76% of dogs and was associated with osteoclast resorption and woven bone formation. These areas were frequently adjacent to the microfractures. Microfractures were also present in specimens where the surface cartilage was relatively intact, cellular irregularities or clefts to transitional zone, as well as severe cases where there were clefts to radial or calcified zone. Only 8% had normal cartilage cellularity. Regarding quantitative scoring, the mean modified histopathology score was 10, which was higher than that of controls. No significant difference between the histopath score for Outerbridge scores of 2, 3, and 4 were found. There was moderate and significant correlation between standard histopathology scores and Outerbridge scores. Microfracture evaluation. And so here is an MRI showing the 3 different severities of the bone marrow lesions. They have focal, focal linear, and diffuse. Microfracture evaluation. The median microfracture grade was 1. 24% only had subchondral microfractures. Microfractures in subchondral bone were contiguous with cartilaginous fissures in 48%. There was a negative linear relationship between microfracture score and outer bridge score. Okay, and here is some examples of histopath. So this one in B, the asterisk shows there's not a lot of cells in those spaces, whereas over here, the asterisks are showing a ton of cells. So this is abnormal, and then B is normal. And then for this figure here, where the arrows are, it's showing that there's loss of tissue there in the bone marrow. And then down below here, if you look at this picture here, those long arrows are showing fissures. So that irregularity, it's not smooth. And then this next one here, A is normal. You can see a nice pink straight line, but then up here where the asterisk is, you lose that pink line. So there's loss of tissue with diseased elbows. Okay. Oh, and then this is pretty cool here. It shows you obviously A is abnormal, B is normal for the medial cornoid process. Okay, discussion. The data from this study are insufficient to validate the use of MRI as a standalone staging tool. Histopathology confirmed microscopic pathology in the subchondral bone and articular cartilage of all the diseased specimens, irrespective of the extent of the arthroscopic and MRI findings. The severity of histologic change in the subchondral bone did not correlate with modified outer bridge and MRI score, suggesting the current clinical assessments of osteoarticular pathology do not provide a very accurate estimate of the true extent of disease. Moderate to severe changes were present in almost all specimens, even those with a low modified outer bridge score. A previous study failed to identify any strong correlation between a radiographic measure of elbow disease, modified outer bridge score, and histopathologic findings, because MRI is generally considered more sensitive and more accurate than plain radiographs. They wanted to assess it. Osteochondrosis was only identified in 4% of lesions. Lesions indicating impaired endochondral ossification were not observed in the other samples. We were unable to identify cartilage islands reported by another study as being the result of either non-physiologic loading or the response of subchondral bone to repetitive microtrauma. 24% of specimens had isolated subchondral microfractures in the absence of an identifiable cartilaginous microfracture. A lower microfracture score was associated with a higher modified outer bridge score. This association may reflect the nature of the disease process. Fatigue of the subchondral trabecular bone appears to be important to the pathogenesis of this disease. Microfracture formation may be the first stage of this disease, explaining a higher microfracture score in the specimens with lower modified outer bridge scores. They're saying there that microfracture, since it happens earlier in disease, you have a lower outer bridge score. But then as the disease progresses, and so microfissures turn into fractures, and then cartilage loss, and then bone exposure, that the modified outer bridge score goes up, even though the microfractures went down. Adaptive bone remodeling then occurs, leading to a reduction in microfracture score, but increase in overall histopath score because of secondary degenerative changes in and around the lesion. Bone marrow hypocellularity was a very consistent histologic finding seen in 92% of specimens. In an experimental model of stifle arthritis in dogs, another study described hematopoiesis and myxomatous transformation of the bone marrow in the areas corresponding to regions of MR signal changes, previously described as bone marrow edema due to capillary leakage caused by a local change in the capillary wall from trauma or tumor, or by increased intravascular pressure. Bone marrow lesions are in fact characterized by fibrosis, lymphocytic infiltrates, and increased vascularization. In people with acute tears of the anterior cruciate ligament, bone marrow lesions are identifiable by MRI in characteristic locations in the femur and tibia in over 80% of patients. In a clinical canine study assessing stifle pathology and MRI, bone marrow lesions of varying size and signal intensity were present in stifles that had a known acute injury, as well as stifles with chronic lameness and no known acute injury. Bone marrow lesions were seen in the knee, ankle, and foot of clinically healthy marathon runners after competition, but similar lesions were also seen in the control group. Bone marrow lesions with no evidence of arthritis was seen in 14 of 34 knees of clinically asymptomatic basketball players. Bone marrow lesions may reflect a normal physiologic response to microtrauma. Changes in limb use are also likely to lead to adaptive bone remodeling, and it's interesting to note that there was significant reductions in or there was an increase in porosity in the tissues from affected dogs. These results are consistent with other reports of increased porosity and may be an indicator of active bone remodeling in response to loading changes. There are a number of potential causes of tissue artifacts and decalcified bone samples: thermal necrosis because of the use of oscillating saw for the subtotal cornoidectomy, understaining or fissuring of the specimen because of incomplete fixation, decalcification or embedding of the bone sample, and shrinkage of the bone marrow during tissue processing. We concluded that the MRI scoring system and the modified Outerbridge score failed to provide a complete picture of the nature of extent of disease. Microscopic evidence of severe cartilage degeneration was evident in cases even with minimally arthroscopic pathology. So yeah, I mean, a study like this is really good. It's great to have different diagnostics. It's hard to get a large sample size. It's hard to say whether or not unilateral versus bilateral elbow disease make the difference. They didn't comment on that here, so I'm curious about whether that affects the results as well. But yeah, this elbow disease is so complex, and we keep finding more and more about it. I'm a huge fan of MRI. If you can avoid doing scoping or surgery for a diagnosis and x-rays aren't reliable, MRI is a great way to go. All right, we'll see you guys again tomorrow. Thanks everybody who watches on the playback. Take care.